And this brings me really to this slide that I keep showing again and again and again. Yes, you are going to have a patient where you may want to rule out a cervical radiculopathy with the number one, the mostly used orthopedic test for cervical radic, which is your Sperling's test, which has a sensitivity of 30%, for God's sakes. This means it's missing 70% of the patients who have a cervical radic. And then you go to, of course, the sensitivity of an EMG, which is 71% or more, actually, in some studies after 1999, that can have by doing just an EMG, and then you can really know exactly what you are doing. So that's awesome. Bart, I want to ask you same question. Give us an actual patient example where the fact that you performed a diagnostic test on a patient really created a difference. It made a difference on how you manage the patient.
You bet. Yeah, probably the one that comes to mind is one from just last week. I had a 40-year-old male that came in. He's a bodybuilder. He also is he does firefighter. And he came in complaining of mild neck pain, moderate to severe anterior lateral shoulder pain with some weakness, and then numbness and tingling and paresthesias in both hands. I'll tell you, prior to doing hands-on diagnostics, I would have been like, oh my goodness, this guy is a train wreck. Where do we start, right? So went ahead, and before starting PT, it just made sense. Let's find out if some of this is coming out of his neck. Let's find out what's going on. And so we did EMG and also ultrasound of the shoulder. Found out he has a partial thickness rotator cuff tear and supraspinatus and tendinopathy of the long-headed biceps. That makes sense for most of our bodybuilders. There, Joe. Yeah. He also had, of course, this numbness and tingling in his hands, predominantly in his first, second, third part of his fourth digit, right? And had moderate carpal tunnel problems on the left, but severe on the right. And from our practice standards through the APTA, there's a little bit of a line in there for me when I'm treating. When I get somebody that on an EMG has moderate, I'm going to try to treat that patient because I have fair amount of success with that. Exactly. But once I get into a severe or very severe category, especially with that right hand, the axonopathy that's occurring there, as well as the demyelination and combination, we have a situation that surgery may be more beneficial for that patient. And so we started to talk to a hand surgeon about that. But from a physical therapy standpoint, we said we can take care of the partial thickness rotator cuff tear of the supraspinatus. We can take care of this tendinopathy of the long head of the biceps, and we started care. And we even started care at the wrist, especially on the left, and are just right now consulting with a hand surgeon as to whether they think that physical therapy care is the best move there on the right. But therein lies a little bit more of a differential diagnosis and a plan of care route because of diagnostics that I would never entertained. I would have never had. As a physical therapist, without knowing a grading system for carpal tunnel, or at that point, not even knowing if this was truly at the wrist, perhaps based on some of those sensitivities, specificities for Tunnels versus Sperling, I may have been treating the neck. Well, he has a little mechanical neck pain, but he doesn't have any radiculopathy. And so it would have been really a little more of a crapshoot just to say, where do we start? I mean, you started with some frustration when I'm painting this picture without diagnostics as a PT, and now we just honed in, knew exactly what we needed to treat for the best optimum success for the patient.
And I've heard you on a past presentation stating something about what you are not going to do on a shoulder patient. You keep saying that, so say that one more time.
Well, I'll tell you, I and a lot of our therapists now within our organization, once you do enough musculoskeletal ultrasound evaluations and combined with your orthopedic evaluation of a shoulder, I will never treat a shoulder again without doing an ultrasound. I'll never do that. Before that, partial thickness tear versus tendinopathy versus just an inflammatory process or strain versus full thickness tear. I'll tell you what, there is a wealth of knowledge that comes through that transducer head, through that ultrasound. They can't achieve in any other way unless you are willing to do a $3,000 on MRI on every single patient that walks through your door, which is a disservice to them. Ultrasound is where it's at. I'll never treat another shoulder again without doing an ultrasound, period.
Thank you.
Hey, Demi, real quick. One thing too, like as Bart is talking about, is we're missing the patient buy-in. So a lot of therapists across the country have trouble with patient compliance to visits, this and that. When we can diagnose this from the get-go and actually they start seeing the improvement right away, the patient buy-in is huge. And that's what we've seen, and that's not something that's hard to, kind of relate to this, but we've definitely seen it in our practice.
I think if I can interrupt, Joe is completely right. One of the things that we started to try to track was what is the consistency with just percent arrival with the patients that have a post-operative condition. They're very, very high. We find that they are 90+%. Now, with other patients that we're trying to save them from surgery, sometimes they're quite a bit less. But when we interject and put diagnostics in and can show them their problem, they get a lot closer to that post-operative scenario because just like Joe said, their buy-in goes way up. They can see their problem. They can see the progress through diagnostics. They understand it far better and their compliance just shoots through the roof.
Yep.
Actually, in the study that I was sharing before, part of the study included patient perception about diagnostics, and 98% of those patients they felt that they were able to manage better their condition and participate in the management of their condition because of the kind of results that they saw from diagnostics. I mean, let's don't kid ourselves. It's very powerful when in your treatment room or eval room, you have a big screen TV and you have the patient in front of you and you evaluate their shoulder or their elbow and you throw on the screen the ultrasound images and the patient moves the shoulder in a specific way and they can see the movement and they can see the tear, they can see the inflammation, and you explain to them about this. That is so powerful. Mm-hmm. So look, it is undisputable that the elevation of the physical therapy practice when they put in diagnostics in the practice, electromyography, musculoskeletal, ultrasound, and the rest, that elevates tremendously the practice and it elevates the quality of the physical therapists who practice in that practice, the clinical quality and clinical ability of these therapists. But at the end of the day, things have to do also with numbers. And for us, I'll share this with you. It is important to understand that there are studies out there. There are studies that show that reimbursement rates for physical therapy, they are in a slide. They will be decreasing at least until the next 2 years. That is what is indicated. And what ends up happening is that physical therapists settle for very low profit margins. The study of the peer-to-peer group of the private practice section of the APTA last year indicated that nationwide profit margin for PT was around 12%, in some cases even less. How are we as a profession will be able to withstand an 8% reduction on Medicare, which still is supposed to happen, or a potential 15% reduction from Medicare for if physical therapy services are provided under physical therapy assistance? So diagnostic testing does provide a higher reimbursement for the insurances that pay for diagnostic testing. They provide a significantly higher multiple compared to a single physical therapy visit.